Vitamin D and the risk of type 1 diabetes. Abstract: Type 1 diabetes is an autoimmune disease resulting from a progressive destruction of the insulin-secreting cells. There is no cure or preventive treatment for type 1 diabetes. However, increased vitamin D intake is currently considered as one of the most promising candidates for prevention. The biological mechanisms for a role of vitamin D in diabetes development are plausible, and as reviewed in this chapter, evidence to support an association has been obtained from various lines of investigation. Conclusions: Type 1 diabetes is a complex multifactorial disease, and it is unlikely that vitamin D deficiency would be the only or perhaps even the main cause. However, there is abundant evidence to suggest that it may have a strong influence on the underlying susceptibility to develop type 1 diabetes, and that it may act as a factor accelerating or promoting progression to disease. It is possible that by using large-dose vitamin D supplementation in infancy, the pattern of immune regulation can be influenced in a manner that makes subsequent progression to type 1 diabetes less likely, even in an individual who is genetically predisposed to develop the disease. It is also possible that by ensuring adequate vitamin D intakes later in childhood, it is easier to defend from the influence of other environmental insults that might otherwise lead to the progression of the overt disease. More studies, including clinical trials, are clearly required to establish the role played by vitamin D in type 1 diabetes, and whether by using supplementation either with vitamin D or with vitamin D analogs some of this serious disease could be safely prevented. Vitamin D and multiple sclerosis. Abstract: the etiology of multiple sclerosis, MS, is unknown, but there is growing evidence that vitamin D deficiency may contribute to MS development. In this chapter we critically review the current evidence from epidemiological studies. Results of case control studies of childhood sun exposure and risk of MS are mixed, but largely support a protective effect with less sun exposure reported by individuals with MS. However, selection and recall biases cannot be ruled out as explanations of these results. Stronger evidence for a role for vitamin D comes from two longitudinal studies. In these studies, dietary intake of vitamin D in healthy adult women and elevated levels of serum 25-hydroxyvitamin D25-O D in young adults were both associated with a reduced risk of MS. Randomized clinical trials of vitamin D supplementation are needed to determine whether vitamin D can effectively be used in MS prevention or as a therapeutic agent among individuals with MS. Summary: overall, the results of epidemiological studies strongly support a protective effect of vitamin D on MS risk and suggest that vitamin D levels are important not only in childhood but also during adolescence and early adult life. If vitamin D truly reduced the risk of MS, the public health implications would be enormous. Considering that almost half of whites and 2/3 of black adults in the United States have 25-O D levels below 17 mol/L, 66, increasing the vitamin D levels of all adolescents and young adults to an average above 100 mol/L would be expected to cause a substantial reduction in MS incidence. If we assume, based on the study among military personnel described above, that 80% of individuals have 25-O D levels less than 100 mol/L, and that this level during adolescence is associated with a tenfold decreased risk of MS, as shown in Fig 3b, then 72% of MS cases could be prevented by increasing 25-O D levels to 100 mol/L or greater during adolescence and young adulthood. This level could be achieved in most individuals by taking between 1,000 and 4,000 IU/day of supplemental vitamin D, 67, 68, 69, 70. Although much higher than the current Institute of Medicine's adequate intake of vitamin D for adults younger than 50, 200 IU/day, 71, and the typical amount in multivitamins, 400 IU, these amounts do not cause hypercalcemia or other known adverse side effects and would result in 25-O D levels still below the average among healthy individuals with regular high exposure to sunlight, 67. A high priority should thus be given to the conduction of a large randomized trial to assess whether vitamin D supplementation in the general population prevents MS. The trial would have to be very large, however, as MS is a relatively rare disease. An attractive option would be a national or multinational study based on randomization of school districts or other suitable units and including multiple outcomes that may be affected by vitamin D, such as obesity, diabetes, respiratory infections, and asthma. Observational data on the effect of vitamin D on MS progression are more sparse and less persuasive, and whether vitamin D has any therapeutic value could be more effectively addressed in randomized trials in patients with MS. Vitamin D and type 2 diabetes. Abstract: vitamin D has been reported to have a variety of non-skeletal actions, including on glucose metabolism. There has been increasing evidence from animal and human studies, as reviewed in this chapter, to suggest that vitamin D may be important in modifying risk of type 2 diabetes. Vitamin D is thought to have both direct, through activation of the vitamin D receptor, and indirect, via regulation of calcium homeostasis, effects on various mechanisms related to the pathophysiology of type 2 diabetes, including pancreatic beta cell dysfunction, impaired insulin action, and systemic inflammation. The evidence from human studies comes primarily from cross-sectional and a few prospective observational studies showing an inverse association between vitamin D status and prevalence or incidence of type 2 diabetes. Because there is paucity of trials that have specifically examined the role of vitamin D in prevention or treatment of type 2 diabetes, it remains to be seen whether improving vitamin D status plays a role in the prevention or treatment of type 2 diabetes. Conclusions and future directions: an inverse association between vitamin D status and type 2 diabetes is suggested based on the available evidence to date. However, the lack of large prospective observational studies that have measured 25-OD as the exposure variable and the lack of randomized trials specifically designed to test the effects of vitamin D limit any firm conclusions. Type 2 diabetes is a multifactorial disease, and it is unlikely that vitamin D deficiency would be a major cause of the disease or a major therapeutic target. However, vitamin D sufficiency may have a role in preventing progression from glucose intolerance to clinical diabetes in high-risk populations. To better define the clinical role of vitamin D and calcium as potential interventions for prevention and management of type 2 diabetes, randomized trials specifically designed to test such a hypothesis are needed. Role of vitamin D for cardiovascular health. Abstract: the prevailing medical opinion up to the 1960s held that vitamin D was a risk factor for cardiovascular disease, arising from research showing that megadoses of vitamin D caused arteriosclerosis in animals. However, the development of competitive protein binding assays for 25-hydroxyvitamin D25-O in the 1970s showed that only a small proportion of body vitamin D comes from diet, with more than 80% synthesized from sun exposure. A 1981 review of the epidemiology, which found that cardiovascular disease rates increased in winter with increasing latitude and were reduced at high altitudes, led to the hypothesis that ultraviolet radiation, by increasing vitamin D levels, protects against cardiovascular disease. Since then, observational epidemiological studies have reported inverse associations between serum 25-hydroxyvitamin D levels and risk of cardiovascular disease. However, randomized clinical trials are required to confirm that vitamin D protects against cardiovascular disease. Several mechanisms have been proposed for the putative protective effect of vitamin D against cardiovascular disease. These include beneficial changes in cardiac function, blood pressure, including endothelial function, insulin resistance, and inflammatory processes. Summary of possible mechanisms: vitamin D may protect against cardiovascular disease through a number of mechanisms. First, these may involve remodeling of connective tissue resulting in hypertrophy of cardiac and smooth muscle caused by elevated levels of matrix metalloproteinases, for example, MMP 9, 83, 84. Second, nitric oxide-mediated endothelial dysfunction, which has an etiological role in coronary heart disease, 118, 119, may also be involved, resulting in increased arterial stiffness and pulse pressure. Lastly, Low vitamin D levels may alter both the innate and acquired immune systems to increase the inflammatory process involved with atherosclerosis, endothelial dysfunction, and insulin resistance to increase risk of cardiovascular disease and associated components such as hypertension and insulin resistance. 120, 140, 141, vitamin D, renin, and blood pressure. Abstract hypertension, or high blood pressure, is one of the most prevalent health problems in the world. Hypertension increases the risk of heart attack, heart failure, stroke, progressive atherosclerosis, and kidney disease. Accumulating body of evidence from epidemiological and clinical studies has demonstrated a connection between vitamin D deficiency or insufficiency and high blood pressure and cardiovascular problems in humans. However, until recently the mechanism underlying this link was unknown. The finding that vitamin D negatively regulates the renin-angiotensin system, a central regulator of blood pressure and cardiovascular functions, provides a mechanistic insight into this observed connection. Recent genetic, physiological, biochemical, and molecular data obtained from cell and animal studies have demonstrated an inhibitory role of 1,25-dihydroxyvitamin D1,25-O-D in renin gene expression, and this is consistent with the inverse correlation between circulating 1,25-dihydroxyvitamin D levels and plasma renin activity seen in humans. The finding of 1,25-dihydroxyvitamin D as a negative regulator of renin expression also provides a molecular basis to explore the use of vitamin D analogs as novel renin inhibitors for therapeutic purposes. Recent data have demonstrated that vitamin D analogs used in combination with the classic renin-angiotensin inhibitors can block the unwanted compensatory renin increase and thus markedly increase the therapeutic efficacy. This combination strategy can be applied to a number of renal and cardiovascular diseases. Conclusion: accumulating body of evidence from a large number of epidemiological and clinical studies have demonstrated a connection between vitamin D deficiency or insufficiency and high blood pressure and a number of cardiovascular problems in humans. However, until recently the mechanism underlying this link was unknown. The finding that vitamin D negatively regulates the RAS, a central regulator of blood pressure and cardiovascular functions, provides a mechanistic insight into this observed connection. Recent genetic, physiological, biochemical, and molecular data obtained from cell and animal studies have demonstrated an inhibitory role of 1,25-O-2D in renin gene expression, and this is consistent with the inverse correlation between circulating 1,25-O-2D levels and plasma renin activity reported in humans. The molecular basis of this negative regulation is that ligand VDR disrupts the CAMP signal pathway, a physiologically important stimulatory pathway involved in renin gene expression. The finding of 1,25-O-2D as a negative regulator of renin expression also provides a molecular basis to explore the use of vitamin D analogs as novel renin inhibitors for therapeutic purposes. Particularly, recent data have demonstrated that vitamin D analogs used in combination with the classic renin-angiotensin inhibitors can block the unwanted compensatory renin increase and thus increase the therapeutic efficacy. This combination strategy may potentially be applied to many renal and cardiovascular diseases in which inhibition of the RAS is used as a treatment method. Overall, the physiological and clinical implications of the knowledge gained from these studies are profound. Role of vitamin D and vitamin D analogs for bone health and survival in chronic kidney disease. Abstract: chronic kidney disease, CKD, is accompanied by reduced conversion of 25-hydroxyvitamin D to 1,25-dihydroxyvitamin D and is often also associated with a deficiency of 25-hydroxyvitamin D. These and other metabolic changes can lead to secondary hyperparathyroidism and a range of disorders of bone turnover, mineralization, and volume, the most prominent of which is osteitis fibrosis cystica. Attempts to prevent this disorder have led to widespread use of vitamin D receptor agonists, but may increase the risk of adnamic bone disease. Beyond its use in regulating bone metabolism, Several studies suggest that vitamin D may influence survival in advanced CKD. Potential mechanisms for this effect are likely to influence cardiovascular disease, the leading cause of death in CKD. Alterations in left ventricular function and the renin-angiotensin-aldosterone axis appear to be modulated by vitamin D. We discuss these and other aspects of the role vitamin D may play in the CKD population, as well as the current state of evidence supporting therapeutic use. Summary: chronic kidney disease is accompanied by a host of metabolic changes that lead to a reduction in the production of in response to 1,25-dihydroxyvitamin D. The consequent hyperparathyroidism results in excessive bone turnover that culminates in osteitis fibrosis cystica. Therapy with active vitamin D analogs can suppress PTH and reduce the risk of high turnover bone disease, though it may also increase the risk of the low turnover adnamic bone disease. An increasing number of observational studies now suggest that vitamin D's effects may extend well beyond its role in management of osteodystrophy. Several observational studies now suggest a significant overall and cardiovascular specific survival benefit. These studies alone cannot prove that activated vitamin D itself is the cause of improved outcomes, but have served to generate exciting hypotheses regarding the potential therapeutic benefits of vitamin D. Animal data demonstrate that important cardiovascular changes may result directly from vitamin D action on the myocardium and renin-angiotensin axis. Vitamin D, via influence on innate immunity, may also prove important in sustaining a response against bacterial infection in this population as well. The fascinating biology revealed in these animal studies combined with observational data in humans is encouraging. Clinical trials are currently underway to determine the relevance of these exciting findings to use of vitamin D in humans with CKD. Role of vitamin D and ultraviolet radiation in chronic kidney disease. Abstract: the decrease of kidney function includes exocrine and endocrine capacity. Our group developed a schedule of serial UV irradiation in patients with end-stage kidney disease on dialysis. We used sun-simulating UV lamps with two different procedures. Whole-body irradiation was done in a standing position in a cabin. Partial body irradiation should integrate UV radiation into the measure of routine hemodialysis treatment. We irradiated only the ventral part of the legs, approximate 15% of skin surface. Using a thrice weekly exposure with both procedures, maximal increases of circulating vitamin D were found after 8-14 weeks. Between 14 and 26 weeks, parathyroid hormone levels lowered and bone mineral density increased. Physical capacity and muscle strength improved, as well as cardiocirculatory adaptation and parasympathetic tone, with a reduction of the disturbances of cardiocirculatory neuroregulation. No serious events and no melanoma skin cancer were registered over a total observation period of 15 years. In our experience, the increase and normalization of all circulating vitamin D metabolites, and the skeletal and the pleiotropic effects seem to be superior to enteral or parenteral application without major side effects. Vitamin D and UV exposure in prevention and treatment of chronic kidney disease. The vitamin D deficiency in CKD patients, and especially in patients on dialysis, is an independent risk factor for the function of many organs and/or metabolic and enzymatic pathways, as well as for overall and cardiovascular mortality. 9, 72, 73, 68. On the other hand, approximately 50% of the elderly, incipient patients manifest a need for dialysis treatment due to the primary diagnoses of arterial hypertension, approximate 20%, and diabetes mellitus type 2, approximate 30%. For both diseases, vitamin D deficiency is also an independent risk factor. In addition to the impairment of the vitamin D metabolism, with the course of CKD and due to a reduction of physical capacity and multiple comorbidities, people with renal insufficiency often are sun-deprived. As documented in the K/DOQI guidelines, vitamin D as the measure of vitamin D status and the basis for extrarenal autocrine hormonal action of vitamin D has to hold within or supplement into the normal range, 74, 13, 1, 2. As demonstrated, The health benefits of UV exposure in patients on intermittent hemodialysis are in accordance with the experiences within the literature for all other groups of the population. Moreover, we had found no major side effects. Therefore, regular outdoor sun exposure during summertime, April to September/October in latitudes GT45N/S and/or serial subarachnoidal sun simulating UVB irradiation should also be recommended as measures of prevention and treatment in people of all stages of chronic kidney disease. Role of vitamin D in rheumatoid arthritis. Abstract rheumatoid arthritis is an autoimmune disease that causes pain, swelling, and deformity of the joints and may result in other systemic effects. In animal models, vitamin D has been shown to suppress autoimmunity. However, in humans the role of vitamin D is less clear as to the effects on rheumatoid arthritis. There do appear to be suppressive effects of specific disease mechanisms. However, epidemiologic results on the effect of vitamin D on the development of the disease are contradictory. A better understanding of the rheumatoid arthritis immune system and the effects of vitamin D is needed before conclusions can be drawn. Clinical, animal, and epidemiologic studies of vitamin D and rheumatoid arthritis. The remissions and flares associated with rheumatoid arthritis have also been studied in relation to further the understanding of the disease process. Women with rheumatoid arthritis have reported remission of their symptoms during pregnancy, which often flare postpartum. An analysis of various cytokines and modulators of the immune system was performed and found that cytokines and substances that suppress immune function, IL-12, cortisol and 1,25-dihydroxyvitamin D3, were higher in the third trimester of pregnancy compared to postpartum, and TNF, an immune function stimulator, was lower in the third trimester and rebounded postpartum, 58. Since studies of other autoimmune conditions have shown a latitude effect with prevalence, and the fact that vitamin D levels fluctuate with seasons, researchers looked at these issues as well as the relationship with rheumatoid arthritis severity. Latitude and seasonal effects were observed in both winter and summer, with the northern latitude having lower serum levels of 25-OD in rheumatoid arthritis patients compared to controls. Additionally, both patients and controls had lower levels in the winter compared to the summer. However, mixed effects with regard to disease activity as measured by a rating instrument were observed in this same study, 59. A prospective cohort study that followed over 83,000 nurses for 28 years reported on the geographic variation and migration patterns of subjects with new-onset rheumatoid arthritis. Place of residence at birth, age 15, and age 30 was assessed. Subjects living in the western United States at all time periods had the lowest risk for rheumatoid arthritis, and those in the Midwest and Northeast had the highest. One possible explanation was UV exposure, which stimulates the production of vitamin D, 60. In a study using C-reactive protein levels as the measure of disease severity, the C-reactive protein levels were worse for subjects with low levels of 1,25-OH2-D compared to those with higher levels, whereas no relationship was seen for 25-OD. This was true irrespective of whether subjects were taking corticosteroids or were not taking corticosteroids, 61. Controlling for disease treatment and duration, similar results were obtained in another study looking at vitamin D metabolism. This same study found a seasonal difference in serum vitamin D levels, 62. Patients with recently diagnosed rheumatoid arthritis were also assessed for serum levels of 25-OD and 1,25-O2D and early disease activity. Mean levels of both vitamin D metabolites were lower for patients satisfying American College of Rheumatology criteria for rheumatoid arthritis. Patients deficient in 25-OD at baseline had worse disease activity and severity at baseline and 1-year follow-up. 25-OD showed a stronger relationship than did 1,25-O2D for disease activity and severity, 63. Rodent models have produced supporting evidence showing the suppressive inflammatory effects of vitamin D in relation to rheumatoid arthritis. Kant Orna, who had studied the effects of the administration of vitamin D analogs in mice with experimental autoimmune encephalomyelitis, a multiple sclerosis-like disease, extended her studies to mice with collagen-induced arthritis, an inflammatory disease with similarities to rheumatoid arthritis. The incidence of the arthritis in the mice treated with vitamin D was reduced by 50%, and those who did get arthritis had milder symptoms, 64. Similarly, in a study by Larson, Matson et Alabama, 65, they administered a vitamin D analog at various time points to rats that were immunized to induce collagen arthritis. Collagen-induced arthritis was inhibited in rats that were injected prior to or around the time of immunization, and in those that were administered the vitamin D analog after immunization had a reduction in the severity of their disease. This study suggested that the timing of exposure of vitamin D relative to the pathogen exposure was important on the outcome. The animal studies further confirmed the suppressive effects of vitamin D on the immune system. Recognizing the benefits of vitamin D not only for bone mineralization but also for suppression of immune activity, vitamin D has also been studied as a treatment for rheumatoid arthritis. Administration of alpha-calcidiol for 3 months resulted in an improvement of disease activity in 89% of patients, 66. Another assessment of the nutritional status of patients with general rheumatology compared to patients with osteoarthritis showed lower serum levels of 25-OD, suggesting that new guidelines and greater attention to the assessment of nutritional status of rheumatology patients with regard to vitamin D need to be enacted, 67. Based on the lack of rheumatoid arthritis prevalence in sub-Saharan Africans, McCarty advocated a vegan diet rich in omega-3 rich fish, along with supplementation with vitamin D as a prevention strategy for rheumatoid arthritis, 68. Similar to the suggestions of the previous findings, a review article on the topic suggested that a more widely advocated assessment of vitamin D status and treatment in the clinical setting was warranted, given the weight of evidence of low vitamin D status in rheumatoid arthritis patients and the potential benefits of suppressing the immune response, 69. There are very few epidemiologic studies that have assessed the association between vitamin D and rheumatoid arthritis. 2 prospective cohort studies that have been published have produced contradictory results. Both of these studies were based on self-report of dietary intake of vitamin D. The Iowa Women's Health Study had 11 years of follow-up of 29,368 postmenopausal women who were over the age of 55 at baseline and developed documented rheumatoid arthritis after baseline. This study found a protective association with increasing levels of dietary/supplemental vitamin D intake but did not include any measures of sun exposure, 70. The Nurses' Health Study had 22 years of follow-up of 186,389 women who were aged 30-55 at baseline and developed documented rheumatoid arthritis after baseline. This study did not find any effect of dietary/supplemental vitamin D intake and did include a proxy measure for sun exposure early in life, 71. A third study from Amsterdam that measured serum levels of 25-OD in blood samples of 79 patients and matched controls collected prior to onset of rheumatoid arthritis looked at the association of serum levels of vitamin D and newly diagnosed cases of rheumatoid arthritis. They looked at 3 time frames prior to onset and found no association with the development of rheumatoid arthritis when compared to matched controls, 72. Studies on the relationship of vitamin D in the etiology of rheumatoid arthritis are contradictory and need further investigation. Vitamin D has a role in specific mechanisms of the immune system of rheumatoid arthritis patients. However, a comprehensive understanding of the individual mechanisms on the complete activation of the immune system is not clear. There are multiple possible areas of action in which vitamin D may impact on the pathogenesis of rheumatoid arthritis, especially given the extensive effects of this hormone. Vitamin D has been shown to suppress T-cell activity through several actions and to modulate cytokines that can alter the course of the disease. Whether the effects of vitamin D are limited to disease severity/progression or have a role in the etiology is not completely clear. Ongoing research is leading to a better understanding of the immune system with regard to rheumatoid arthritis. The knowledge gained will provide better information, in the future, on the role of vitamin D in the pathogenesis of rheumatoid arthritis. Vitamin D, respiratory infections, and obstructive airway diseases. Abstract. Over the past decade, interest has grown in the effects of vitamin D on respiratory infections and obstructive airway diseases, OADs, such as asthma and chronic obstructive pulmonary disease, COPD. Studies suggest that low vitamin D levels increase the risk of acute respiratory infections, which may contribute to incident wheezing illness and cause asthma exacerbations. Although unproven, the increased risk of susceptible hosts to specific respiratory pathogens may contribute to some cases of incident asthma. Likewise, the effect of vitamin D on COPD, while intriguing, is largely unknown. Emerging evidence provides biological plausibility for some of these respiratory findings. For example, vitamin D-mediated innate immunity, particularly through enhanced expression of the human cathelicidin antimicrobial peptide, is important in host defenses against respiratory pathogens. Vitamin D also modulates regulatory T-cell function and interleukin-10 production, which may increase the therapeutic response to corticosteroids in corticosteroid-resistant asthma. Finally, low vitamin D levels may have a role in the pathogenesis of allergies, including anaphylaxis. Further studies, especially randomized controlled trials, are needed to better understand vitamin D's effects on respiratory infections and OADs. Conclusions. Over the past decade, interest has grown in the effects of vitamin D on respiratory infections and obstructive airway diseases, OADs, such as asthma and chronic obstructive pulmonary disease, COPD. Observational studies suggest that low vitamin D levels increase the risk of acute respiratory infections from diverse respiratory pathogens in both lower and upper airways. Post hoc analyses of randomized trials on vitamin D and bone health support this possibility. This increased risk of infection may contribute to incident wheezing illness in children and adults and cause asthma exacerbations. Although unproven, the increased risk of susceptible hosts to specific respiratory pathogens may contribute to some cases of incident asthma. Likewise, the effect of vitamin D on COPD, while intriguing, is largely unknown. Emerging evidence provides biological plausibility for some of these respiratory findings. For example, vitamin D-mediated innate immunity, particularly through enhanced expression of the human cathelicidin antimicrobial peptide, HCAP, 18, is important in host defenses against respiratory pathogens. Vitamin D also modulates regulatory T-cell function and interleukin-10 production, which may increase the therapeutic response to corticosteroids in corticosteroid-resistant asthma. Finally, low vitamin D levels may have a role in the pathogenesis of allergies, including anaphylaxis. Further studies are needed to better understand vitamin D's effects on respiratory infections and OADs. Randomized controlled trials of higher dose vitamin D supplementation, for example, at least 1000 IU/day, particularly in the winter season at higher latitudes, will help clarify if vitamin D can prevent or reduce the severity of respiratory infections. In turn, these insights may prove helpful in preventing OAD exacerbations and the achievement of disease control.